Thank you, Dr. Nagia, and also thank you to Dr. Norona and the team at this review course for inviting me to speak today. It's truly a pleasure to come back again and share with you some of the geriatric oncology updates over this past year. Let me put it on full screen. Just give me a minute. Hope you can hear me clearly. So today, thank you. So today I'm going to talk to you about some geriatric oncology updates. Some are abstracts, publications. It's not comprehensive, but I have decided to focus on certain key studies which I feel be beneficial for everyone to be aware of and learn from. These are my disclosures. So I've broken it down into some abstracts from big meetings like ASCO, important PSYOP publications, JGO publications, and others. And I will summarize right at the end. So I'll start with ASCO oral presentations. So this was one of those presented at ASCO this year by the Notch team. Basically, this is a study coming out of, sorry, let me get that to, so this is a study coming out of the United Kingdom, basically looking at 2,049 patients who were treated with immune checkpoint inhibitors across 12 centers. And data from the study was accrued from 2016 to 2018, basically looking at single agent immune checkpoint inhibitors or doublets for a few groups of tumors, namely melanoma, non-small cell lung cancer, and renal cell carcinoma. I think prior to this, there have been data, specifically subgroup analysis from a number of clinical trials looking at the role of immune checkpoint inhibitors in older adults. Most of them have reported subset analysis for older patients in terms of efficacy, but very little is known about toxicities. So this was a very timely real-world outcome study. So in short, patients who were aged 75 years or above 75 years treated with anti-PD-1 therapy in the standard of care setting derive similar benefit to younger patients. So efficacy data somewhat confirmed what we knew prior to this, which was these patients benefit as much as their younger counterparts in terms of efficacy. However, in terms of toxicity, patients treated with single agent PD-1 ICI therapies had similar tolerability as well. So this is very good data that supports the use of these therapies in older adults. You will, of course, hear a lot more later on when Dr. Steer will be talking to us specifically on this topic of immunotherapy in older adults. Another resource I would recommend would be this one. It's a JCO series, special series published in the middle of this year. And we looked at a number of different systemic therapies in older adults. So this particular article I've written together with my co-authors there, including Carolyn Presley and Melissa Wong, specifically on immunotherapy in older adults. So it's a review paper. We had also done similar review papers for targeted therapy and systemic therapy as well. So if you have time, this is a series of articles that I would recommend you read. Now, another interesting study that was presented at ASCO this year builds upon some of the data that was presented at ASCO 1 year ago, mainly looking at the role of GA and its intervention in older adults with cancer. So this was called the 5C study coming out of the Canadian group led by Martine Putz. And the study design, basically these patients were enrolled, about 350 of them were enrolled across 8 centers all over Canada. And they looked at baseline QOL, IADL, G8, and EQ5D scores. And they were then randomized to an intervention arm where they had minimum monthly phone calls by a registered nurse for 6 months and reassessment by the doctor as needed, or the control group, which had usual care. And the outcome of the study looked at quality of life, specifically the EORTC QLQ C30, each month for the first 6 months and on month 9 and 12. Unfortunately, the study did not meet its primary endpoint. There was no quality of life benefit for geriatric assessment and intervention, which was surprising because the studies that were presented the year before, at least 3 of them had shown significant improvement in terms of quality of life. And 2 of them have been recently published, and I'll talk to you about them in a short while. One of the reasons the authors gave for why this was so was perhaps due to COVID, because of the dropout effect, specifically in the intervention arm, that made it difficult to actually assess quality of life, and indicating there were non-random missing data as well that had caused these results, which were surprising. Nevertheless, I guess we'll have to wait for the final publication to see what actually happened in this study and why this was so. SIOC had a number of important publications, but I think the most important of which was probably this, published very early this year in January in Lancet Oncology, an update to the 2011 SIOC 10 priorities. At that point in time, Dr. Martine Exterman had come up with 10 priorities covering 3 key areas: education, clinical practice, and research. This time, a decade later, the group has now updated those 10 and it's become 12 priorities listed here. As you can see, there's an additional pillar now, which is collaborations and partnerships. And the key thing about these priorities is that the hope is for oncologists across the globe to see how they can prioritize their resources, use this to get policy initiatives going within their respective countries. Of course, it is not easy to implement every single one of these priorities, but based on what the current geriatric oncology environment is within your country, it may be a useful document for you to look through to provide some kind of outline or a template to follow in order to achieve some of the goals that we hope to achieve for our older patients with cancer. So if you have time, again, this is a document that we would recommend you read. Now, briefly to run through the JGO Artiuria Award winners, this was recently presented at our annual meeting. So this award was named after a renowned geriatric oncologist, was a giant in the field. Unfortunately, we lost to an unfortunate accident a couple of years back. And it is in honor that JGO named this award for up-and-coming geriatric oncologists and research that we feel that JGO felt was important to highlight. So there were 2 winners this year. The first one was from Denmark, and that was on the impact of tailored follow-up intervention on CGA in older patients with cancer. It was a randomized control trial. And the other one was something that came out of the United Kingdom, looking at treatment choices for older women with primary operable breast cancer and cognitive impairment. It was a prospective multi-center cohort study. So I'm going to spend a bit more time on 2 what I would consider pivotal papers in the field of geriatric oncology. So these studies actually have changed clinical practice and bolstered support for the role of GA in older adults with cancer. So I'll first start with the one published about a month ago in the Lancet by Dr. Mohili and her team at the University of Rochester. It was an evaluation of geriatric assessment and management on toxic effects of cancer treatment, or the GAP-70 study. So a cluster randomized study. Now, the basis behind this was the fact that older adults have comorbidities, disability, geriatric syndromes, all related to aging. And the goals of treatment in the palliative setting would be to minimize toxic effects, maximize function, and improve quality of life. So with that in mind, the group then went about a nationwide to create a nationwide cluster randomized control trial with a plan to evaluate providing geriatric assessment summaries with management recommendations to oncologists in order to improve clinical outcomes for older adults with advanced cancer. Patients were recruited from practices from University of Rochester, NCI Community Oncology Research Program, which is a national network in the United States. Now, eligibility criteria, here patients who were 70 years and older were enrolled into the study. They needed to have 1 or more geriatric assessment domain impairments apart from polypharmacy. They had incurable advanced solid tumors or lymphoma, planned to start a new cancer treatment with high risk of toxic effects within 4 weeks, and more than 1 chemotherapy agent or non-chemo agent with more than 50% prevalence of grade 3 to 5 toxic effects, as determined by the primary oncologist, were the inclusion criteria criteria for patients to be eligible to enroll into this study. Geriatric assessment were done according to the domains that many of you are familiar with, so it's all listed there, and they were then randomized to receive either recommendations on treatment interventions based on the GA or the control arm which had standard of care with no recommendations. The primary outcome was to see the proportion of participants who experienced grade 3 to 5 adverse events within 3 months of initiation of treatment. Secondary outcomes included effect of GA on treatment intensity and on survival. So in terms of patient characteristics, it was relatively well balanced. There were more Caucasian or non-Hispanic white patients in this study than other races. GI was the most common cancer type seen, followed by lung cancers. And in terms of physical performance, they were relatively well balanced between both arms as well. However, there seemed to be more patients who had cognitive issues or social support issues in the geriatric assessment intervention group compared to usual care. Similarly, there were slightly more patients, 30%, who had previous chemotherapy in the geriatric assessment intervention group compared to just 22% in the usual care group. Nearly all, or 90% of these patients had stage 4 cancer. And the number of impairments or number of impaired geriatric domains were on average about 4.5 and balanced between both the arms. Now let's head on to the results. So here you can clearly see that patients in blue were those in the geriatric assessment intervention group actually had fewer toxicities or grade 3 to 5 CTCAE toxic effects over the 3 months compared to patients in the usual care group. 51% in the intervention group versus 71% in the usual care group. And when you break them down into hematological and non-hematological toxicities, clearly you can see in both these areas, the geriatric assessment intervention group had fewer toxicities experienced over that 3-month period compared to their counterparts in the usual care group. Now, in terms of chemotherapy use, the most commonly used agents were taxanes and platinums, and a high proportion of patients in the intervention group received less intense combinations. As you can see here, in terms of single agent chemotherapy, 23% versus 18% in the usual care group. Both groups had planned use of GCSF prophylaxis, and those numbers were similar across both arms. Now, in terms of treatment intensity, when you look at the prevalence of reduced dose intensity at cycle 1, it was higher with the geriatric intervention group or assessment intervention group versus usual care. However, at 3 months, that had reversed. And this is likely related to toxicities and the need to actually reduce dose for the group that had usual care. And overall, on average, there was still a lower relative dose intensity, or at least a mean RDI for patients on the geriatric assessment intervention group. In terms of overall survival, there was no difference. So in spite of having lower doses at the start for those in the geriatric assessment intervention group, it did not impact survival. Now let's look at other outcomes. So common geriatric assessment guided management recommendations included more frequent toxicity checks, changes to treatment schedule or dosing, medication reconciliation, providing education materials, referrals to allied health. So these were the type of management recommendations that the geriatric intervention group had versus standard of care that less likely had these kind of interventions. What I want to highlight here is that there were a few things that were found to be different between the arms over that period. Over the 3 months period, there were, in terms of falls, there were fewer falls. In terms of number of overall medication used or discontinued before starting cancer treatments was also lower with the geriatric assessment arm. And also the number of prescription medications discontinued was lower as well before starting cancer treatment regimens. So a few discussion points. It met its primary endpoint. The study met its primary endpoint with the intervention reducing risk of serious toxic effects by 20%, reduced dose intensity, did not compromise survival, and also fewer falls, more medications discontinued, and reduction in polypharmacy. Also, providing relevant information about geriatric patients can improve upfront decision-making because these patients are underrepresented in clinical trials. Hence, they're vulnerable to receiving treatments that have higher or greater risk than benefits, causing them lower rates of treatment completion and early mortality. Now, there are some limitations. Interventions were only done once at a single time point, and low-intensity interventions were delivered by oncologists and not geriatricians. This, however, may not be a bad thing because in many institutions, there are not enough geriatricians to actually assist with these things, so it can be something challenging. Now, the study was not designed to examine non-inferiority of treatment between the study groups, and oncologists determined toxic effects which might have led to bias, although there were attempts by the investigators to reduce this bias by having a masked clinical team at the research base to review toxic effects apart from the primary oncologists. Response rates and patient-reported outcomes was another bias as well, because higher prevalence of patient-reported outcomes might have led to this. For example, higher reporting of falls, and there was a selection bias, especially exposure to chemotherapy to both arms were different, slightly higher in the intervention group versus slightly lower in the usual care arm. So in conclusion, GA and assessment and management should be considered standard of care in older patients, and this can be help reduce treatment toxicities as well as fall and polypharmacy. Quickly going to go through the next study, which is GAIN, which was also published not too long ago. One of the few studies that was presented at ASCO last year that, of course, drew a lot of attention because of the data that has come up from the study. So it's a randomized controlled trial, and it was done to evaluate efficacy of specific geriatric assessment-driven interventions versus standard of care on chemotherapy-related toxic effects and other clinical outcomes that's listed right in front of you. Now, patients enrolled were slightly younger, so they had to be 65 years and older, unlike GAP 70, where they were 70 years old. Again, solid malignant neoplasms of any stage, not just advanced stage, and starting new chemotherapy regimens. These patients were found to fit this criteria, were eligible. They then got on to getting a baseline GA, a SPICES assessment, which I'll describe in a short while, and a CAR chemotherapy toxicity risk score. They were then randomized in a 2-to-1 fashion to either the GAIN arm or the standard of care arm. And subsequently, they were followed up for duration up to 6 months from the start. So SPICES involved looking at certain kind of, geriatric assessment criteria, including sleep disorders, problems with eating, pain, incontinence. So these are all geriatric syndromes. So patients were assessed according to this list there with interventions for them as well. And the CAR score is something many of you will be familiar with. Again, something led by the late Dr. Ati Huria. And patients had this at baseline before initiating therapy. Now, those in the GAIN arm had MDTs done on them, referrals were written when they had deficits to intervene on, and chemotherapy had additional support from a nurse practitioner. While standard of care just had chemotherapy, and referrals were done at discretion of the oncologist. Now, these were some of the interventions briefly, so you can get this from the paper itself, so I'm not going to go through in detail. So I'm just going to give an example. As you can see there, for functional status, those who had limitations had exercise prescription, they had evaluation for fall risk, home safety evaluation, gait strengthening, and some Reiki therapy. So study outcomes were primary outcome of incidence of grade 3 or more chemotherapy-related toxic effects, and secondary outcomes listed there, including advanced directive completion, ED visits, unplanned hospitalization, early discontinuation, and so on. In terms of patient characteristics, as you can see, age range there showed that some were very old, up to ages of 91, mainly female patients, white, and again, GI cancers predominate amongst them. And most of the patients were stage 4, although there were also some patients who were stage 1, 2, and 3. In terms of interventions, you can see here, out of the 3,971 potential interventions, about 76.8% were implemented in the GAIN arm versus just 12.5% in the standard of care arm. Now, when you look at grade 3 or higher chemotherapy-related toxic effects, or the primary outcome of the study, it met its primary outcome. Patients on the GAIN arm actually had fewer hematologic and non-hematologic side effects, and this was clinically and statistically significant. As you can see here, the common hematological side effects included anemia, neutropenia, and non-hematological side effects included infection, fatigue, and hyponatremia. The other secondary outcome that was met was an absolute change in advanced directive status. In terms of survival and analysis, again, not very different between both arms. So in summary, there was a significant reduction of more than 10% in terms of grade 3 or more chemotherapy-related toxic effects, and more likely, these patients on the gain arm were more likely to complete the advanced directives, and this did not impact overall survival compared to standard of care. There's some limitations with a single tertiary center study where MDT was available, and there was potential bias from patients and treating oncologists who were aware of the treatment assignments. So with that, I've come to the summary of my talk. So recent robust real-world data supports the use of immune checkpoint inhibitors in older adults with cancer, and Dr. Christopher Steele will be talking to you about this shortly. Updates to the SIOP priority statement makes it an important document to help lead policy changes in the field globally. 2 large randomized trials were published in high-impact factor peer-reviewed journals highlighting the benefits of GA and intervention on quality of life and reduction of chemotherapy-related toxicities. And SIOP leads the way in educating cancer specialists across the globe in the latest development of GO. In the last minute, I'm just going to talk to you briefly about SIOP. Some of you are familiar, some of you may not be. This is probably the leading organization for geriatric oncology globally. We have over 1,700 members from 80 countries. And yearly, we come together at an annual meeting to share and discuss latest research and development in geriatric oncology. We also conduct some advanced courses, and I'm going to talk a bit about that in the next slide. This is the history. We were established more than 21 years ago, started by Dr. Paul Calabresi and some of the doctors that are listed there. And for the first time this year, we have a leadership from Asia, and I hope with that it will stimulate interest specifically in countries in the region like India. And I've seen a lot of wonderful activity coming out of India specifically over the last 2 years, and I hope this will continue in time to come as well. So I'm going to talk a bit about the advanced course. So for some of you who are interested on some of the key principles of geriatric oncology, so this runs over just 2 days and it's virtual, so you can sign up for it online. So please feel free to get on our website and sign on to this course if you want to know more about geriatric oncology and go a bit into some depth in learning about some of these principles and how you can apply them for your patients in your own clinical practice. The other thing is please join us as a SIOP member. Again, the membership rates are also, we have special membership rates for patients, for oncologists or scientists from low middle income countries. So to make it attractive for all of you to join, so please do consider joining us as a member. With that, I'd like to thank you for your time and your attention.
Thank you very much, Dr. Ravindran. That was really a very comprehensive review of the publications in the last year, which really stressed the fact that there has to be an increasing recognition of geriatric assessment as a part of our treatment protocol. There is, however, something glaring. As a radiation oncologist, I'm mentioning this, that there seems to be very little attention outside the medical oncology space in the way treatments have to be modified and the way patients have to be assessed for surgery or for, so there's a lot of, there are publications out there that tell us that, treatments have to be modified and perhaps outcomes are impacted. And yet, it's not come together as nicely as it has in medical oncology. And what would you have to say about that?
Interesting comment, Dr. Nanja. And I think there is some truth to that. I don't deny the fact that the development of geriatric oncology in other non-medical oncology related areas may not be as mature or well developed. But while saying that, I think it's a growing space. So within SIOP, we have interest groups. So we have an interest group for geriatrician, for surgical oncologists, because surgeons have been using these tools for a while now as well for older cancer patients in the peri-operative space. So some call it prehab. That means just before surgery, they actually undergo geriatric assessment and intervention to get them fit. And there's a lot of outcomes that have been shown to have improved from this kind of interventions. Radiation has similarly come into the place as well. So there's a radiation interest group that you may want to consider joining, and that group is looking at multinational studies like this. I think sometimes the key thing is collaboration. To do these studies within a single center is very hard. You may not get enough patients and support, and so that's the short answer.
Right. I'd just like to mention here that we are writing up a pilot. I work at the Proton Center in Chennai, and we are actually writing up a small pilot to put all the patients who come to the hospital through a geriatric, all patients above 65 through a preliminary geriatric intervention. We have a geriatrician visiting us as a regular clinic, and we hope that in the radiation space, there'll be something that we'll be able to put together. Are there any comments, please, from any questions or comments?
Yeah. I have a question, sir. In palliative setting, after geriatric assessment, what we are seeing, we are decreasing the dose in most of the patients. But is there anything like that? The number of patients undergoing
Sorry, could you repeat that? Meaning by giving them lower doses because of geriatric intervention, does that increase best supportive care? Is it? Sorry, I need a...
So my question is that the number of patients undergoing best supportive care, have they also decreased after geriatric assessment? Are we treating more patients, though with a modified dose?
Okay, that's a very good point. So the role of geriatric assessment is to personalize. A lot of it is done by ECOG, so it's quite, I would say, rough, right? It's not refined. And by doing that, yes, we may be actually putting people into the best supportive care box when they could be getting modified intervention. Usually, it is not the clear-cut best supportive care group, it's the vulnerable group. Broadly, when we do these assessments, patients will be classified into 3 groups: the fit, the unfit. The unfit will be best supportive care, and the vulnerable group. And the vulnerable group can be, put into the fit group if they undergo some form of geriatric intervention. And only with geriatric assessment, some of them can be assessed appropriately enough for us to know what to do with these patients. Give modified treatment or intervene, maybe even give potentially full dose treatment. So to answer your question, the answer is yes. Geriatric assessment will reduce the number of patients who we may have given up on and placed under the best supportive care group. And some cases we have because of age. So patients may come in relatively fit, but they come in with the case notes writing that they're 85 years old or 90 years old. You immediately have these kind of preconceived notions that they're going to have all these comorbidities. They may not be, physically able or have the support that's required for these systemic therapies. Yeah. But conversely, we may be also giving some of these patients who are less fit and should not be getting full dose of treatment based on the fact that they walked into the room, they looked fit, but they have 10 comorbidities, multiple drugs that they are on, and organ function that may be deranged. But then just based on eyeballing them, which was what a lot of us do because of lack of time and knowledge about geriatric assessment, may unnecessarily cause harm. So you must think about the converse as well. But it's less likely that, and more of us giving up on patients who should be getting therapy.
So one more question, that the toxicity profile of the immune checkpoint inhibitors and chemotherapy are slightly different. So if we have an option to use both, so what do you think one should prefer in the geriatric age group? Is immunotherapy more easier to give in this group of patients? Such as we see in our head neck cancer patients, if they are elderly, we are not keen on giving them chemotherapy. Might be giving immunotherapy, we find it slightly safer in this group of patients. Your opinion on that, sir?
So I think you have to go back to first principles. So that would mean what is standard of care for anyone, regardless of age, right? So once you have that in mind, and for the example you gave will also apply for lung cancer as well, right? For those patients in the first line who are non-oncogenic driven lung cancers, it's IO plus systemic chemotherapy. Now, that's where geriatric intervention comes into the picture. If, based on that assessment, patient is found to be fit, there's no reason to decline them the combination IO chemotherapy just because of age or other factors. So I think slowly you need to remove age out of your thinking process and go to geriatric assessment as what helps you define who is fit and who's not fit. Bottom line is, if a person is fit to receive combined IO chemotherapy, they should get it because data has shown that that will benefit them the most. So we shouldn't deny them the chemotherapy because we think that they may suffer more toxicity. We should actually do these assessments and assess their toxicity risk first. And based on that, make the call on whether they should or should not get the chemotherapy element. Of course, IO is generally well tolerated. I think a lot of data supports its use in older adults without a lot of assessments being required. But if combination therapy is standard of care, patient is fit, they should get standard of care.
Thank you, sir.
Thank you very much, Dr. Ravindran. I'm sorry I'm having to call a stop to this very interesting discussion because we have run out of time. And please continue to discuss in the chat box.
So, Dr. Nangia, may I ask one last question of Dr. Kanesvaran? My apologies.
Please.
Thank you so much for a really eloquent update on all the major breakthroughs in geriatric oncology and so rapidly. I have a little bit of a controversial question for you. I think based on the GAP 70 plus and the GAIN study, we know that toxicity reduces. And I think from GAP 70 plus, we got a sense that it was primarily from dose reduction. In our setup, at least, we are seeing that we are not really able to do a full geriatric assessment for a lot of our patients. So would you recommend, based on that, taking a leap of faith and saying, just if you aren't able to do a full geriatric assessment and the patient looks a little bit frail from your eyeball test, just upfront dose reduce and then build up gradually?
That is a safe strategy. So I would say that's a good idea. But what maybe a middle ground is consider a geriatric screening tool, like G8 or something. Takes a couple of minutes and something they can do, while waiting outside a clinic, or the nurses can administer as soon as, any patients above 65, automatically you get your nurses to just do a G8. Gives you a rough idea rather than eyeball, because I think any tool out there, and that's why we have moved away from the term comprehensive geriatric assessment to geriatric assessment. Because I think any tool that you can use out there within the limitations, and I can understand where you're coming from, Vanita, because a lot of us practice in clinics in Asia that are chock-a-block full. We don't have the luxury of doing a full geriatric assessment or sending to a geriatrician. So we need to come up with methods that are, quick and easy and adds value to the eyeball test. So I fully agree with what you said. It's safer to go with something lower and then push doses up, because it is in the palliative setting, of course, and quality of life is paramount. So it's a great strategy, but I think if you can spare the 2 to 3 minutes, add on a screener, and that may help you a little bit in making the call.
Thank you.